Hello, everyone. Welcome to the first episode of Pink Podcast. I'm Dr. Sama Zibde. I'm a breast surgeon working in Al Zahra Hospital, and I'm delighted to start this amazing educating series of podcasts discussing all the aspects related to breast health, breast surgeries, breast issues that every woman, have concerns about. Welcome, Dr. Poonam Bijlani. She's my guest today for the first episode of the Pink Podcast. Let me introduce her. Welcome, Dr. Poonam Bijlani.
Thank you very much.
You're a consultant plastic and reconstructive breast surgeon.
Yes, I'm a plastic and reconstructive surgeon, and I take great interest in breast reconstructive surgery. Mm-hmm. I always like to weigh in on and make a comment about breast reconstruction. I think the most important thing is that the fact that we are empowering women with a choice for breast reconstruction. You've been a breast surgeon for so long, and it's a hard journey.
Almost 30 years. And I think you have also
That's right.
similar experience.
That's right. Over 35 years in reconstructive surgery. And I think what happens in this hard journey of breast cancer when it's announced to a patient, and how difficult it can be for some of the women. I think when we talk about breast reconstruction for breast cancer, we are not talking about aesthetic surgery at all.
Yes.
This is restorative surgery.
Yes.
Just as we would like to reconstruct if, for instance, one lost a finger for an accident, I think it's absolutely the same reason why a breast reconstruction should be done for a woman undergoing breast cancer surgery.
I agree 100%. Well, women visit us. We start the journey of assessment, diagnosis, workup. And if, sadly, a woman is diagnosed with breast cancer, I think part of improving the way she interacts with the whole journey and recovers well is also to assure her that there is a breast reconstruction option that is valid and that's available, which is your role.
That is exactly right. And I think this is about empowering women with choices.
Yes.
Whether she chooses to finally undergo reconstructive surgery is entirely her choice.
Yes.
But the fact is that she should know what is on offer and what is available to her to make those choices.
Can I ask you briefly, just to make it simple, what type of reconstruction we can offer women? The main two types.
That's right. So broadly, in general, breast reconstruction has what we call as prosthesis, or more commonly as is known in the general parlance, is implant-based surgery.
Yes.
And the other option that we have, where we use the own tissues of the patient, is called autologous. As the name explains, it's auto, which means your own, and logous, which is basically using your own tissues. So the tissues in that case can either be from the back or from the abdomen or even the thighs.
Yes.
And then later, and what is also catching up and has gained a lot of interest in this past decade, has been about fat grafting.
Yes.
So I like to think of fat grafting as the final touches that we give in a breast reconstruction.
Rather than a primary
procedure. That's right. It's when we actually layer the breast reconstruction. It all depends, of course, on the patient's goals and how far she wants to go with the breast reconstruction. But I think this adds all those little fine nuances that implant or autologous, or as we call as muscle transfer surgeries, cannot do. I think also we have to understand that these are often staged procedures.
Yes, this is a great question. It was on my mind.
Yeah.
So women ask me, what is immediate reconstruction versus delayed?
That is correct. That is correct. So a lot of patients, depending on what kind of other adjuvant therapies they may have, for instance, they may have chemotherapy, radiotherapy, may follow the surgery or may even precede the surgery. So there may be a little influencing of the other therapies as far as breast reconstruction is concerned. So it's often a staged procedure. For instance, if it was an prosthesis-based reconstruction, then we start with an expander, or sometimes, though not commonly, we may go straight in for an implant.
What is an expander, Dr. Poonam?
So basically, an expander is what I would say as a deflated silicone balloon. And this is to actually keep the space patent between the chest wall and the skin. Because
I want to ask you a question that often I get asked by the ladies, the patients. Can they defer inserting the expander later, like a month or 2 months after following the mastectomy? Or it has to be done immediately, simultaneously?
Well, if there is no gross contraindication to an expander, most patients can go in for an immediate.
So this is the ideal scenario, is I finish the mastectomy and then we insert the expander.
Absolutely. However, there may be some reasons, or even for the example, a patient choice where she's I'd say she's not ready to make that choice. Delayed reconstruction can always be done. So we do have what we call as immediate and delayed, as you've.
So let's go back to the expander. So once I'm done with mastectomy and you have this deflated silicone balloon, as you described.
That's right. That's right. So basically, this is keeping the space patent. Once the patient has healed, her skin wounds have healed, then we start the expansion, which is basically installation of saline into that balloon, which can gradually be, we may inflate it every week or as per the patient's convenience. And unless, of course, she's undergoing another therapy. And then we may want to get it done in time so that we can make sure that she's on time for the other therapies.
Yes.
But otherwise, if there's no such hurry, we let the patient take her pace.
Into account further treatments such as possible chemotherapy, radiotherapy, and we time the expansion procedure to fit exactly within that frame.
That is right.
Excellent.
We have to, in that case, we are a little time bound, but for those patients who don't have that, we can do it at the patient's pace.
They often ask me, what is the fastest time you can expand actually?
Well,
like if the wound has healed.
That's right. Once the wound has healed, then we usually like to expand it every week. However, that would depend on how the patient reacts to it.
Yes.
Okay, and also the
skin to skin,
that's right.
Patient to patient.
That's right. These are all individualized and completely tailor-made. There's no one size fits all, and I think that's the beauty about the reconstruction. And I think also the fact that when you have an all-women's team, I think it somehow makes it easier for the patient to discuss all these little things which they may not have been so comfortable with the opposite gender.
Agree. And then once the expansion is completed, again, when do you think women should time the second surgery, replacement of expander with implant? Is there something that's standard, or again, it's case to case?
That's right. It is always case to case. But in broad terms, if she has had radiotherapy following the expansion, etc., in that case, we like to wait for a minimum of 6 months.
And why is
before
that,
we
Dr.
do the
Poonam? What's the effect of radiation on the skin?
So radiation in general does cause some changes which may not be visible from without, but from within, there is a deep fibrosis and scarring that occurs. And because of that, we have to allow the breast to finish that process before we exchange it, so that once we have exchanged it, the changes are minimum. So we have a more predictive outcome.
I agree. And basically, this is about the minimal duration from 2, just to educate the ladies about it.
When having finished radiotherapy, having completed radiotherapy, I would say a minimum of 6 months. That is ideal. If for some unforeseen circumstances, but we don't advocate it earlier because, like I said, we want the scars to mature.
I personally tell them to discuss it with you, of course, but I tell them, wait, a year is better.
That is correct.
Because then the skin becomes a little bit softer.
That's right. That's right. The further we move away from radiation, the better the recovery of the skin has been, and therefore less chances of an implant getting extruded.
And I always have this question from the patients. Is the second surgery, which is replacement of expander with implant, as difficult, as prolonged? What would you describe the surgery with?
It is not at all as hard as the previous surgery was. nor is the recovery process difficult at all. In fact, because the space is already made,
Created.
already present, now all we have to do is take off the expander and put in the implant through a much smaller incision, and usually this is absolutely possible in daycare.
And they ask me, why do we have to remove the expander?
So the expander is a temporary prosthesis. We do have expanders called as Beckers, etc., which can also double up as an expander, an
Yes,
implant.
they have, I think, a gel shell.
That's right. There's a gel in the front of it, and there's saline behind it. It also has a good strong shell. But remember, because there is saline in technically what is the implant, saline implants have their own disadvantages. One is, of course, they have a higher rate of deflation.
Yes.
The second thing is you can often hear the saline splash.
Yes.
And that may not be agreeable to some
and
of the
texture
patients.
actually from...
Yes,
Yeah.
because fortunately the front of the expander implant is silicone. The texture may not be greatly affected. However, like I've said, deflation is always a problem, as well as some of them hearing the sound.
In contrast to the implant has more natural feeling.
Yes, it does. It does. The implants that we have, there's been a quantum leap as far as implants are concerned. We went from what we call as the smooth around implants, then we had contractures there, then we came to the textured implants, and then we talked about lymphomas happening in those.
Yes.
And then now we've come to what is a nano texture, which is in between the smooth and the textured
We
implants.
talk about the texture, we mean the shell or the cover, the outer surface of the implant.
That's right.
Yes.
So all the implants are silicone shell.
Yes.
It's the texture of the shell that
Yes.
has changed.
Yes.
And now we find what we call as ergonomics implants. So which is very much like live tissue, so to say. So as the woman lies down, the implant flattens, just mimicking
Like a natural
normal
breast.
breast. Absolutely.
Yes. And I hate to ask this question, but I think I should. What are the most common complications with expander implant surgery? That can happen.
Well, fortunately, the complications are an exception, not the rule.
Yes, that's great to
Yeah.
hear.
So, well, I would say the most dreaded complication would be infection for us.
Yes.
Because infection in a patient who has undergone a large surgery and also with an implant, that the bacteria like to impregnate on the surface of the implant.
Yes.
And that is what we dread.
And I think the infection rates are higher when women have received chemotherapy or
Yes.
they are immune compromised,
That's right.
etc.
Also, like you mentioned, patients who've had anterior chemotherapy or adjuvant chemotherapy where immunity is already low, they've undergone a surgery which has been long, which is also contributes to infection. However,
Yes.
when we do it in good hospitals, like as in Al-Zahra, etc., where there is a
Precautions.
that's right, where the precautions are, which we take it very, very seriously.
Of course.
Is we find these are very, very low complication
Good to hear.
rates.
But if, in case these complications happen, I think also it's not the end of the reconstruction journey.
No. It is not at all the end of the road. I would call it a bend in the road.
Yes.
So it's a little speed breaker,
Yes.
but it is not the end of the road. Even I can tell you first is that we fight to
Yes.
save that expander
Yes.
or implant.
Yes.
If all measures to save it have or salvage it, as we call, has failed, then we may need to explant it. But the patient can come back 3 months later when it's all settled, and we can once again start the process. So it's
And
not the end.
This is great to hear. And this takes us to the second type of reconstruction, which is the autologous. Can you tell us briefly about types of the muscles,
That's
skin, fat, etc., that we can harvest from our own bodies?
That's right. So we do have what we call as autologous. And autologous is where we may use a muscle from behind your back, and that is commonly known as the latissimus dorsi flap. It does involve a little longer procedure. It may also entail a little scar at the back, which I can tell you fades greatly over a period of time. And the other procedure is what we have is the Ep flap, which has gained a lot of popularity also.
Deep inferior.
Yes, that basically is the name depends on the vessel on which this, the blood vessel on which this reconstruction is based.
So these are great surgeries, but I think the duration of the surgery is longer, and it entitles surgery at two different sides of the body. It's kind of like challenging, but it's doable, of course.
Of course, everything is doable.
Between autologous and implant expander-based reconstruction.
Right. So
is it the patient's choice or ours as surgeons?
No, all choices are with the patient. However, we do want to guide them.
Yes.
Absolutely.
I agree.
So, and what is the guidance is the education.
Yes.
So we do educate them about every procedure. We
The
tell
pros
them
and cons
the
of
pros
every
and cons about
surgery,
each
of
of them,
course.
what can go wrong, what can't go wrong, what are the outcomes, when are the outcomes. So the timelines and all of that we discuss in great detail, even over 2 or 3 consultations, answering every question so that when the patient goes in for surgery, she has made an educated choice about it.
This is very important. I think people have to be realistic about their choices, possibilities, and I don't think, we should not discuss complications. In fact, we should, because once they know that these complications can happen and we have measures to handle them, to treat them, to manage them, I think this is a more clear and practical way, and it helps us all, as you said, to reach to an informed decision, I would say.
That is correct.
Informed decision.
That is correct. It is very, very important to discuss every aspect of the surgery so that the patient is well prepared mentally.
Yes.
You can imagine that this is not, though the woman makes the choice, but it is the entire family that gets affected.
Yes, I agree 100%.
So we have to, this is a journey of empathy, kindness, and we have to give them, allow them to exercise this choice.
Yes.
There is nothing right or wrong, and I say this for women who even choose not to have breast reconstruction. So these are all choices they make, and there's nothing like a right choice or a wrong choice. Choices are made in circumstances and with the facilities
we are with
available.
them through this journey. We
Absolutely,
guide them.
absolutely.
We guide them. And I think sometimes it's also, our experience. We believe that this type of reconstruction is favorable, or it's easier or faster or it's better. So we guide them, but we don't make the choice on their behalf.
That is right. Having been in practice for 30, 35 years, both of us, we have seen hundreds, if I may not say thousands, but of these patients who come. And therefore, we do allow our experience to weigh in with what choices the patient makes. So, for instance, a patient often asks me, "Doctor, what do you think is the best choice for me?"
Yes.
And I say, very often I'll say, with these circumstances, I think this would be a safer choice for you. And because we can predict the outcome. Finally, what do we have to do? We have to make this patient feel her body is balanced. She has regained her body balance.
Yes.
And this is about rehabilitating a patient completely.
Yes.
So I think that when we talk about breast reconstruction, we are actually closing the loop on breast cancer. So we have to complete the journey for the patient.
I agree.
So that is why I think it is so important that every patient at least knows that she has a choice for breast reconstruction, and what are those choices.
Beautifully said, but I also would like to emphasize on the point that patients have to be realistic.
Yes.
This is not an aesthetic surgery. I know you do a lot of aesthetic procedures. This is reconstruction.
This is not an aesthetic surgery. It is a reconstructive surgery. But at the same time, I like to think that all reconstructive surgery should be aesthetic.
Should be, if we can, of course. We try
correct.
our best.
That is correct. So, which is why we come into fat grafting.
Yes.
Because I think fat grafting gives you that final layer.
Yes.
That's right. I would look at it as a painting. When you go back and you want to touch it up, that's exactly what fat grafting does.
How is fat grafting done? Are there contraindications?
Well, fat grafting is done where we take fat from one area of the body, the fat is processed, and then we inject it into certain areas of the breast. In patients who have got small
Abundant.
breasts, or etc., it may be possible to just only do fat grafting for them as a procedure, but we have to remember these are staged procedures because we have to allow the fat to grow. And
basically, how many sessions you think, or procedures?
Well, I usually tell patients it may take 3 to and sometimes even 4 sessions
until they reach the desirable.
That's right. It
outcome.
all depends on patients'
the size
goals.
of the breast.
That's
amount of fat patients have in their bodies.
There are some women who are just happy with the implant or the autologous surgery, and they just want to say, for instance, wear a bikini and possibly go to the beach, or where they are, even if they are camouflaged in their clothes, they just want that. But there are some women who like to push the envelope, and I'm saying there's absolutely nothing wrong with that. It all depends on everyone's goals.
Body image.
That's right.
Yes,
your own
confidence.
goals
Exactly.
For restorative surgery.
And let me ask you about nipple reconstruction. In certain tumors, we have to sacrifice the nipple. So in that situation, what are the options you offer?
Yeah, there is good news for that as well. We can very much reconstruct the nipple. There are various ways we can do it. We can use the breast tissue itself, which is there to reconstruct the nipple. Sometimes we can borrow from the other side. We can use cartilage. There are lots of things. And then for the areola, which is the pigmented area around the nipple, we can tattoo it. We can use skin grafts.
We've seen some patients our own patients who have done 3D tattoo.
That's right. There's some incredible
Yeah.
tattooing there. And it, like I said, it all depends on what the patient wants. But the fact is that it's available.
Yes, that's excellent and good to hear. And let me ask you a bit about other aesthetic procedures that are considered, unfortunately, here, by insurance companies, the perception of it, this is purely aesthetic, but it's actually therapeutic. Specifically, I'm talking about breast hypertrophy. And with all these complications, the neck pain, the shoulder pain, the spinal pain, dissatisfaction with the appearance, the heaviness, etc. I think this is a medical condition. It's not purely aesthetic.
Well, for the longest time, it used to be covered by insurance, and unfortunately, the procedure, if I may say, fell into disrepute because it was abused in some ways. But for a deserving patient, yes, and there are still some insurances that would cover it, provided she fulfills the criteria.
What are the criteria?
Well, they need to be they should not be above a certain BMI. There should be demonstrable, neck pain or cervical spasm, etc. And some other criteria as well, which is listed on the insurance websites. There has to be a fungal infection, demonstrable. And like I said, this is reserved for the most genuine patients.
Yeah.
But
it's good to hear. Because we have a lot of patients who really suffer from this, and they think that this is a pure aesthetic procedure.
That is correct. Okay. And I think it's probably a discussion for another day.
Yes.
Because that is a whole topic. That is another topic.
Well, Dr. Poonam, it's good for everyone to know that in every journey, specifically related to the breast, breast cancer, breast disease, etc., there's a team. We work in collaboration. We don't take individual decisions. A discussion is always there, and openness, clarity.
Absolutely. Every single woman with breast cancer and who chooses to proceed for reconstruction goes through what we call as a multidisciplinary team discussion, commonly known as the MDT, which is what I call the wisdom of the crowd.
Yes.
And that is very, very necessary. So every single guideline is adhered to and is monitored, if you like, is medically audited in this.
Excellent, yeah.
So we do not deviate from what are the prescribed norms and what are
Yes.
the prescribed
But
procedures.
we tailor based, as you said, on
Yes.
case to case.
It is
Exactly.
always tailor-made because
within the context
that
of
is
the
correct,
guidelines.
because there are so many choices that
Yes.
the woman makes,
Yes,
and therefore they are tailored to every individual. This, but so much gratitude for our patients for making
Yes.
this choice, and for allowing us to be
They
part
are
of
brave,
this journey.
beautiful women, and we are there to help them, always on their side, trying to support them, trying to offer practical solutions for every, let's say, obstacle they face during
That is
this
right,
journey.
as it should be, and we salute them. We absolutely
Yes.
salute these brave, strong women, and let's celebrate the journey. I think that is something that we have
Now
to
we
do.
are now in October, so
That's right.
What's your message?
My message is very, very clear, is that today, from when I started as a general surgeon 35 years ago, when breast surgery was nothing but a slash across the chest, we made a quantum leap in how we
course.
look at breast surgery and how we look at reconstructive surgery. So empower yourself with the knowledge, with the options available
And that
to you.
are choices available.
And please ask every question that you have from your breast surgeon, because things have absolutely changed. And I'm sure there is something for every woman in this.
Great to hear. Thank you.
Thank you for having me.
Thank you for being on my side. And we've helped many, many women.
Yeah,
And I think we
gratefully.
will continue to work together
Yes.
and help more
Absolutely.
to be beautiful, cured from cancer, and back to their normal lives.
And may our endeavors be blessed. Thank you so much.
Thank you.